Okay, so today we are going to talk about chapter 18, which is chronic pelvic pain. I'm sure that you have scanned someone by now that has come in with just pelvic pain. Sometimes it's during a certain part of their cycle, sometimes it is just constant. But chronic pelvic pain is common and responsible for approximately 10% of gynecological visits. Two common causes of this are endometriosis and long-term consequences of pelvic inflammatory disease. Typical symptoms include dyspareunia, I'll never be able to say it, dyspareunia and dysmenorrhea. Dyspareunia is painful sex. Some causes such as muscle trigger pain cannot be recognized on ultrasound and require physical therapy. Chronic PID is related to an earlier infection with PID. It's most common and usually unrecognizable unless the sonographer locates the area of tenderness. Our big thing that we're going to be looking for with chronic PID is a hydrosalpinx, which is this image on the screen. It's going to look more like a tubular structure than a round cystic mass. So that's one way that you can distinguish between the two. This one looks like a seahorse, but you want to try to elongate it in the adnexal region to see if it can look like a tube. And usually you can call it by watching it look tubular instead of circular. With hydrosalpinx, the walls are going to be thin because it's chronic, it's not acute. With acute PID, the walls are going to be thicker and inflamed, and you're going to probably have more pus in the tube. You can also have masses that can cause chronic pelvic pain. A large, slowly growing uterine or adnexal mass may cause pain, of course, to neighboring organs. A huge one that we see that causes pain is adenomyosis. You remember adenomyosis is when endometrial tissue moves into the myometrium, creating a lobular myometrium. Some of the sonographic signs for this are going to be a Venetian blind sign, shadowing, a thicker heterogeneous myometrium. Most of the time, this will be more on the posterior side. In this case of this picture, it's more on the anterior side, but this is worth noting in your report that the uterus appears heterogeneous and lobular. And you can sometimes with adenomyosis, what you're going to see is it almost looks like a mass, but you can't distinguish exactly that it is a mass. It just is indistinguishable with the rest of the tissue around it, and that's another sign. These patients are going to have heavy bleeding, heavy periods, enlarged tender uterus, painful sex, and painful periods. Infertility can be also like it's not necessarily a reason why a person would have chronic pelvic pain, but it can be with chronic pelvic pain, you can have infertility because endometriosis is a really common cause of pain, and it also is a cause of infertility. Often the typical masses seen with endometriosis are absent because they're more like implants that are very difficult to see on sonography. However, if we get a loculated mass of endometriosis, it's called an endometrioma or chocolate cyst, if you remember that. You can also have implants on the abdominal wall, bowel, and bladder. Adhesions can also cause chronic nagging pelvic pain if they've had it, like a C-section, abdominal surgery, if the endometriosis has caused adhesions, a hysterectomy. These are common reasons for adhesions to occur. Now, adhesions are very difficult to see on ultrasound unless there is ascites or free fluid. But it's good to know what we can kind of look for in this. So it can be caused by a previous infection or surgery. It may be seen with endometriosis, or it could occur occasionally with malignancy. So there's some indirect signs that we can look at. If the uterus is very deviated to the left or right, or extreme retroversion that doesn't seem to let up, there could be an adhesion holding the uterus in that place. If the ovary is positioned high or low in a lateral position that does not appear, that appears immovable, that could be another reason that indirect sign that we can see. This is the most reliable one that I think. Ovary is located adjacent to the uterus and cannot be moved with a vaginal probe. If you see an ovary that is like posterior to the uterus, which does occur, but most of the time what you can do is when you're scanning, you can kind of put a little bit of pressure and it will clear out. It'll kind of move a little bit with the ligament. If it doesn't do that and just seems like solidly in place, this can be a really reliable sign that there could be an adhesion holding the ovary and next to the uterus, causing pain. And if an ovary feels stiff or immobile when pushed and remains adjacent to the bowel, that can also be a sign. So what do we do in our reports when we suspect an adhesion? Because we can't see it, we can't definitely, say it for sure. What we can do is describe what we think. So if the uterus is like very deviated to the right, I would put that in the report. Uterus appears deviated to the right, immovable. With an ovary, you could put ovary appears adjacent to uterus. Just give the doctors a hint that there could be an adhesion, and then they can take it from there. You can also have ovarian remnant syndrome, which is when one ovary is left while the doctor takes everything else. Now, why do they leave one ovary? Well, if the person is premenopausal, this ovary will still do a good job of producing the hormones needed for the body to function properly. However, sometimes with uterine surgery, adhesions can occur. And if the ovary does get caught in some adhesions, when it's producing its Graafian follicle and corpus luteum, it can cause pain because it's kind of stuck. You can also have deep pelvic endometriosis, which is very difficult for us to diagnose unless we see a large homogeneous mass like this endometrioma. We will definitely want to make sure that we are looking in the cul-de-sac and looking for masses, not only on the ovary, but in the adnexus and in the posterior cul-de-sac. Pelvic congestion syndrome is another reason for chronic pain. It's when you have dilated veins in the region of the ovary. So if you see a lot of like worm-like veins on bilateral sides, especially the left side, you need to note that in your report because that could be a reason why they're having chronic pain. However, it is 10% of people do have dilated veins. So it could just be a coincidence, but it's worth mentioning in your report. There's some other reasons for chronic pelvic pain that don't include the uterus and ovaries. You can have diverticula, irritable colon, and a huge one that we see is interstitial cystitis, which is inflammation of the bladder wall. Now, if you've ever had a UTI before, you can tell that it just hurts and it's hard to distinguish the pain between, is it uterine, is it like ovary, is it bladder? It all just kind of hurts. So it is something that we might be scanning a person for pelvic pain when it tends to be something else, but it's good to make sure that we are looking to see if everything looks okay on our end. Okay, so our clinical scenario for today is a 30-year-old woman with a history of infertility has painful intercourse and vaginal discharge. She has had 3 sexual partners in the last year. What condition would you look for? I'd love to hear it. Okay, you guys have a good day.